Aber die noch gelandet?
Hello. Dr. John, you are mute yourself.
How you been, Omar?
How are you?
Oh, so the connection's okay today, huh?
Okay, next. It's very nice. Thank you very much for you.
Welcome.
Thank you very much for you.
I'll be back.
Okay.
Greetings, everybody. Is the presenter here yet? I guess Dr. Summer's not here yet. Right, I gotta unpin my video. Oh, okay, no. Is the presenter here yet? Everyone's quiet. I need someone to tell me. Is Samra going to be the presenter, I imagine? Okay, we'll just wait. Okay, there's Omar. So how are things, Omar? So, okay? Yeah, you're mute.
Okay. Alhamdulillah, everything okay now. Alhamdulillah.
It's
From
quiet.
Allah, every good
Okay.
thing, every good. Okay. From people, not good.
Oh, okay.
Here, not good from people. From our God is very good. Alhamdulillah. Thank God.
Okay. Well, you are
Yeah,
in
Idlib.
Syria.
At Syria, Idlib.
Where are you now?
I am at Idlib. Idlib city, Syria.
Oh,
Now.
Syria. Oh my
Idlib
God.
city. Okay, I'm at Idlib city. I finished my clinic and finished my and the emergency. Okay, and then prepare patient, finish patient. I come to lecture.
Oh, okay.
Okay, thank you very much for you.
Okay, Bradab, are you there?
Hello, Dr. John.
Hey, Brad, I forgot. Man, I should have called you. Did you see the webcast we have with the artificial intelligence?
No, actually, I was unfortunate these days. I'm kind of busy with the hospital and some patients. So I just saw your.
Okay, well, okay, I can't argue with patient care.
Read
No
up.
other.
I can ask you read up.
You remember Omar, right? Omar from.
Dr. Ibrahim Sbeh, I have 4 cases for fungal infection, leg tumor. I have 4 cases now after the last lecture. 4 cases. Can contact with Dr. Sbeh about these things to refer to them. Here, a picture only in Idlib.
I can understand that, Dr. Amar, but the problem is that we have some problems to bring patients from the nearby countries.
Not to bring. I take his opinion about this patient. Patient I can't bring to there, but his opinion about the cases. Okay, this is fungal or not fungal? I think it's fungal. About the last lecture, 2 lectures of Dr. Subeh.
Just to save some time, you can contact him directly on
okay.
email.
Can you give me his WhatsApp? Is better for me. If you can.
Radab, I'll talk to you later about the webcast was great. We had 2 of the biggest Chinese neurosurgeons. Hey, Sarah, how you doing?
Hi, John. Hi, everybody. I'm okay.
Okay.
Hi, Dr. Samer.
Hi, Dr. Radab.
You know Radab.
Dr. Samer, how are you?
Hi. Hello,
Syria.
Dr. Omar.
From Syria. From Baghdad?
Yes, I'm from Iraq, Baghdad.
Baghdad now?
Yes. I'm
okay. I have one patient. I have a patient from Baghdad. Okay. فتيان الشمري. His father. Okay.
Just give me a
Okay.
second.
Welcome.
Sarah.
I congratulate you for the amazing book written by you regarding the vascular lesions, the aneurysms and AVMs and everything. It's really fantastic and just the needed one for exams. Great work, actually.
I'm all right. I'm all right.
Thank you.
Greetings from Nigeria.
Thank you, Dr.
From
Adab.
Nigeria.
Okay, Sam, are you ready to start?
Yes, I'm ready.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach, home of Neurosurgical TV. We have another Iraq neurosurgery grand rounds with Samer Hose. Today he's going to talk about peacock tail aneurysm clipping. And we have a few people in the audience I'll introduce first before I turn it over to, hello, Verdab. How are you?
Hi, Dr. John. I'm fine. Thank you.
Can you please introduce yourself, where you're from and stuff?
Okay, so I'm Rida Al-Khataibi from Jordan, Amman. I've been officially graduated the 6th-year academic residency program and officially certified with the board examinations, the Jordanian board last year and the European board also last year. I'm interested in vascular neurosurgery and I'm always keen
I was just
to-
introducing you just a second. Okay, Verdab. Thank you. Okay, and Omar, that's okay. Omar, can you say hello? Omar from Syria. Go ahead, unmute there, Omar. You're muted there. You'll get it. Get the unmute button there.
I am here.
Oh, there
I
you
want
go.
to hello to everyone and inside. Okay, I am from Syria now. I have Syrian board of neurosurgery, the first one of the neurosurgery. I go to the international congress at KSA and at Syria. I know Yazar Jgil, the father of the neurosurgeon. I take his name, and Dr. Mufti, Osama Mufti professor. I know David Knott, at London. I know Joachim Ortel at German, Deutsch. He's my friends. Joachim
Okay.
Ortel at stores. And I know the big professor, Dr. Jam Bennett.
Okay, well, thank you, Omar.
My
anyone-
papers, my papers, all is gone, is lost it because of what happened at Syria. All my papers, only I have Syrian board of neurosurgery only. Nothing
Okay.
of papers with me.
Very, very good. Welcome, Omar. Okay,
Thank you.
Samer. Okay, Samer, it's all yours, and welcome.
Okay. Thank you, John, and welcome everybody. I have a presentation today about some complex aneurysm and as a case and example. So, is it okay, John?
Yes.
Okay. So, today, as part of Iraqi neurosurgery ground round, I present an interesting case, complex aneurysm, and we perform a modified clipping technique. We just call it the peacock tail tandem clipping for aneurysm. So I'm Samer Hose from Iraq. I'm dual trained vascular neurosurgery, and I have the honor to present today with the Neurosurgical TV and with the esteemed guests. First of all, as I start each lecture, we have the honor by these teachers, mentors, and we are shamefully inferior to them if we do not advance beyond them. And in general, as we know the basics for aneurysm, either we perform surgery or endovascular Actually, it's more complex than this. Now the aneurysm surgery involve simple clipping, complex clipping, bypasses, and for the endovascular option, either coiling or balloon-assisted coiling, stent-assisted coiling, or even flow diverters. So this is in general. For our case today, this is the general algorithm of how to manage the fusiform MCA aneurysm. And our case category is a non-dissecting aneurysm, do not involve lenticular striate artery. So the main option is a clip reconstruction, and the clip wrapping is an alternative. That's the neurosurgical atlas from Aaron Cohen. These are the description of the treatment of giant MCA aneurysm in general, let's say whether saccular or fusiform, to gain proximal control, then distal control, open the aneurysm, evacuate the clot, usually partially thrombosed for giant aneurysm. And after that, you can do complex clipping with different forms. Actually, this is aneurysmography. It's obtained now, not used. It's on is the old form of treatment. And we are here. What's the type of clipping that's suitable? It depends on the aneurysm configuration. Sometimes it's described easier that after control, you can resect the aneurysm and just do simple clipping. Sometimes the clipping is more complex and even more complex with many clips. Initially, when I see this image, I said, why they put such many clips for aneurysm? Why they don't resect the aneurysm and put few clips like the examples before? And recently, Dr. Michael Lawton described this technique of tandem clipping and call it picket fence technique. I usually find this one interesting and put it in my mind in the background. And last week we faced such case. It's M2 aneurysm, insular middle cerebral artery, and it's a fusiform, not saccular. There is no official neck, let's say, and there is two distal M2 branches exiting from the large aneurysm. Actually, it's the size of the aneurysm is 6 by 6. So it's actually larger than the temporal lobe even. So what we did, it's actually different from our plan initially. Our plan is to resect the aneurysm and put opposing clips or simple tandem clipping. What we did is to resect the major part of the aneurysm after internal decompression. Then we put tandem clip, but the aneurysm exactly have a residual neck on both sides, and you will find it within the operative video I will describe in a few minutes. So this angles, let's say the lateral angles, needed extra clipping, and the final shape looks like the peacock tail. That's the idea. That's the final image of our clipping. That's the reconstructed neck. We make a new neck. This is the, let's say, it's not clear here, but I will show you in the video. This is the M2 entering the aneurysm, and the distal M2 is exiting, and these are, this area will consider the new neck. It's already atherosclerosed, calcified wall. It will not grow later, and the aneurysm, it was large, evacuated, partially resected, and the remaining part clipped in this pattern, and this pattern looks like the peacock tail. That's the idea. So it's initially a modification of the previously described the picket fence technique. I will go to the video now, and yes. First of all, I will show you the initial imaging of the patient. John, is the video working and the voice clear?
They're stills right now.
Okay. So initially, this is the CT scan. The patient present with the sudden severe headache and meningismus, looks like a hemorrhage, a delayed presentation, as before 2 weeks have like an incident of rupture, and with a history of seizure. As we know that such giant aneurysm usually presented with mass effect and seizure, we can find that the size of aneurysm, it's about 5.8 centimeters, and 2/3 of the aneurysm already thrombosed, and only the lateral part is viable. And let's see more image. In the MRI, you can find that this is heterogeneous with lamination, typical for giant aneurysm, and you can find the viable part superior and lateral, and other part is thrombosed. So it's MCA aneurysm clear. And maybe in this image, not very clear, but this is the bifurcation. This is A1 and this is M1. And when getting to be the insular part, M2, it goes to be enlarged in this dolichostatic shape. This is the viable part of aneurysm. But I want to show you that the real aneurysm is there. This is the real aneurysm. That's all the aneurysm, and the lateral part is the viable part, and all the other are thrombosed part. So this is a giant one, and the options here are either bypass or clip reconstruction. For us, I think bypass is difficult. Patient is already old age, 67, and I don't have such experience doing multiple bypass at the same location. So I decided to go for clip reconstruction. First of all, this is the initial section of the arachnoid dissection of the sylvian. This is the aneurysm inside. The initial dissection done by our brilliant resident, Dr. Mustafa Adnan. And if you notice that the large aneurysm, yes, already the sylvian opened, just need some proximal opening of the sylvian fissure. Try to get more proximal control. The speed is by 2, just to save your time. And you can notice how calcified and atherosclerosis all the vessel. This is a bridging vein, the anterior temporal vein. Going down to the arachnoid, this is the carotid, tenocarotid supraclinoid. Then the optic to the right, it's a left side aneurysm through typical left pterional approach. So you can find this now. This is the frontal lobe, this is the temporal lobe, this is the sylvian fissure filled completely by the aneurysm. And after that, we are trying to do a dissection from the surrounding. As we know that this is the left side, then this area will be the Broca's area. So we are doing gentle traction, just holding the brain, and try to find if there is any cortical vessel like these to preserve them. These are very critical in such aneurysm, and actually found the 3 cortical vessel. I call them empassage vessel because they just crossing the wall of aneurysm, adhere to the wall, then go back to the cortex. That's critical for the outcome. This one is one of the examples that you can see. This is a cortical vessel going back to the vessel, but at the same time, it's adhere to the aneurysm wall, so dissected with alternate sharp and blunt scissors to preserve the cortical vessel and to separate it from the aneurysm. Try to mobilize the aneurysm. That's the idea, to get more proximal control. Because as you know that, or as you notice that the aneurysm is very hard, very calcified wall. It's not non-mobile. I cannot go to the M1 till now. as we know, we need a proximal control. That's the main step, then distal control. So the cortical vessel is now separated from the aneurysm, from the temporal side. And completing the sylvian fissure, distal part of sylvian fissure, I will skip some steps just to save time. And this is the initial separation from the surrounding cortex, then going back to proximal control. So I want to find what is the M1. This is the carotid. Dissection very difficult, as you can notice that how hard the aneurysm. I pulled the aneurysm with the sucker and the scissor, but it's very tough. And I go back to the, okay, let's decompress the aneurysm first, just to get some space around. I start from this part. It's not a good part because it's a viable. Then I decide to cut bipolarly, using bipolar to cauterize the surface of aneurysm just to make a little bit shrink. And after bipolar cautery to the surface, I can feel how hard the wall just below the, just underneath the bipolar. So I decide to make a little space around the aneurysm using bipolar cautery. This is one of the tricks that usually used for large aneurysms. And after that, we open the aneurysm in more inferior and medial. We know this part is thrombosed, and you can notice how interesting that the layer inside the aneurysm. Actually, for me, I did some giant aneurysm, but not this size and not such thick contents. Just for joking, we say that there is a lot of things. There's bones, calcification, there is nerves, muscles, all inside the aneurysm. You can see these layers and layers. Also, I use the bipolar, not the biopsy forceps, not the micro one. We need a tough instrument. And also, I use the regular scissor, as you see here, not the usual micro scissor, because it's very tough and most of the parts are calcified. An alternative is to remove the internal thrombus with the Kuze, but I feel this one is have control on inside to do the lower part to go more to the M1. And looks like a nerve, but actually it's just layers of thrombosis, and it's interesting to see this combination of very thick thrombus at a part of the aneurysm, and at the same time, yes, you can see it's viable. There is part ready to bleed on the inside the same sac. So for those doing vascular surgery, this is a usual view, and one of the methods just to make a direct clip for the last part you touch, and it's partial controlled. Now making use of the partial decompression going, you can notice the brain retractor just pulling the aneurysm, and here you can notice the M1 giving anterior frontal branch just to the frontal lobe, dissecting more for the M1 to prepare it for temporary clipping and the proximal control. Without the internal decompression, this part is not feasible. I cannot reach this part of the M1, and M2 here is going over the insula. And still I cannot see the entrance to the aneurysm, but I decide to make a proximal control and open the aneurysm and evacuate more. Now you can notice an interesting part of moving the aneurysm like a tumor. It's a little bit looks tough because the speed is by 3 now, and very thick thrombus, hard. Some parts are calcified, but I have a time limit because of the temporary clipping. Actually, it takes more than the expected. Usually, we do the temporary clipping for 10 minutes. In this instance, we take like 17 minutes, but I'm obligated to evacuate most of the parts. You can notice it's not easily removed by the biopsy forceps. I have a time limit because of the temporary clipping. Actually, it takes. Sorry, John. Okay.
Oh, yep.
Okay. So compression. It's look like now as a meningioma, internal debulking of meningioma surgery. And you can notice the role of the assistant. I have a surgeon assistant. We both do the surgery alternating, one surgeon and one assistant, Dr. Haider Saleh. And yes, we are still having more contents inside the aneurysm. I need to evacuate most of the parts so the wall can be clippable. Still, it's not clippable now. You can notice how large this content, this mass inside the aneurysm. And you should be careful while cutting these parts because you may cut the wall. Again, I say that this is the speed, I think, by 3. So it's not, we are in hurry, yes, but not to be not delicate. Now it's a purse string stitch just to hold the upper part of the aneurysm. It's a typical purse string. I don't know this technique, but we are obligated to use it intraoperatively. And just to hold the edges, still there is a large part. Now clipping, because we are reaching the time, we are reaching 15 minutes now, and we want to close the opening and to remove the temporary clip just to relieve the brain for a few minutes and give it another trial later. So it's now open. Still, it's hard. We evacuate like half of the mass. You can notice how active is the aneurysm. Just as a little part still open and very active bleeding from it. We need another clip to control this inferior part of the aneurysm, anterior inferior part actually. All the clips are used with the very large sizes, the largest clips that we have, we use it. And again, trying to do temporary clip and give it another trial to control, to evacuate the remaining thrombus. What is the distal vessels? Yes, these are the M2s here. And still there is a large thrombus. I decide to give it another trial to evacuate most of the parts. These are the M2s. I think it's clear here. And this is the M1 proximal and the M2's distal, or M2 proximal and M2 distal. We put the patties here, just a landmark for us while working on the aneurysm. At this point, we decide to cut more parts of the aneurysm and to evacuate the whole thrombus just to make the aneurysm clippable. I will go to the next steps. Now, evacuation clips. Still, I feel there is a large part. It's not enough for us to leave the aneurysm like this. So we decide to do another trial of temporary clipping to the M2 proximal. You can see the M2 proximal here and the M2 distal going out from the aneurysm, and removing all the clips and Let's can see the cavity of the aneurysm now. Still there is a part. And yes, at this point, we decide to cut more and evacuate the complete aneurysm, and finally put the clips in tandem clipping. Still, there is there will be a few minutes for evacuation. Small cortical vessel, just bleeding. You know, this inside the surgery, at the time you need to focus at another place, there is always a bleeding from here or here. It's a cortical vessel, but it's an active bleeding. Usually this is the act of veins. Sometimes the vein, at the critical moment, veins tend to bleed. So it's now controlled, going back to the aneurysmal sac, open it. You can notice how dilated, and it's not a regular circle. It's a irregular walls with the volume, large volume. Still, there is a large thrombus. You can notice this thrombus. Using scissors, regular pens, even not micro pens, just to make it hold it because it's calcified. And there is a time pressure for us because it's under temporary control. And at the same time, you need to be delicate with the wall. You don't need to puncture the wall with the cutting. It cannot be done bluntly, so sharp dissection is advised at this moment. Now I feel it's better and clippable. You can notice this part, it's dilated lateral part, lateral to the M2, exiting M2. And at this point, we decide to cut the aneurysm and just to complete the debulking process. And the remaining part, we decide to go for direct tandem clipping. We are near the end of surgery. Now this is the last part, doing the clips in tandem fashion. This is the exiting M2. So I need a clip just lateral to it because this is also part of the aneurysm. Now the tandem clipping, you can notice the M1 M2 entering the aneurysm and M2 exiting, and we are forming a new neck for the aneurysm. The neck just to preserve blood flow from the proximal M2 to the distal, and still there is active part. The treatment here is to put more clips in a tandem fashion. That will obligate you to use more clips. As you remember, for a few minutes, I said to you that in my mind, why they use many clips, but you can find here the answer. I feel these clips can be advanced more, so I give it a trial. Sometimes we use only straight, sometimes use oblique to get more space, to block more space. I need some blood to get out from the aneurysm at this point, just to clear the cavity from any residual thrombus. That's advantageous for us. So I keep the bleeding from this side just to secure other part and go back, advancing the clips one by one. But I cannot advance the clips more because this is the exit of M2. I don't need to kink this vessel. Still some active bleeding here. This means that some part of the aneurysm wall is not attached, not opposed well, so more clipping is needed. One more clip, final clip, I think. Yes, it's 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So it's 13 clips. 12 and this is 13, sorry. The total clips put is 13, and this is the peacock. Final shape is a peacock tail. It's a fanning from the neck. This is the new neck formed, and this is M2 entering and M2 exiting. That's the final outcome, just to make sure that everything is okay. You can confirm the patency of M2s by using ultrasound or ICG. We don't have ICG yet, but we can use Doppler ultrasound. Still, there is a mass in the Sylvian fissure, yes, but it's I think it's less than 20% of the initial mass. And as I said, the patient is 60 plus. I don't need more sophisticated steps. The time of surgery, it's around 6 hours from skin to skin. I think it's acceptable for such difficult and giant aneurysm. The brain is intact, clear, frontal, Broca's area. Post-op patient has hemiparesis that's improved over a few days, and some dysphasia that's also improved. And she is now on discharge. That's the final outcome. And I usually make zoom in, zoom out, just a trick for luck. We use it. And that's the idea about our surgery today. As you see the steps of surgery, so this illustration is very demonstrating for it. And that's the idea, to resect main part of the aneurysm and the remaining part to put many clips and to make a neck, just to make blood flow from the proximal artery to the distal arteries. And the final clip shape, as we said, it's a peacock. I have one thing before finishing my presentation. It's okay, John?
Yes.
I want to show the viewer something interesting, actually. I think it's interesting that after the surgery and I think for a few days at 5 p.m. So after the surgery, I opened the Facebook and I found Dr. Mustafa Biskaya, which is one of the good surgeon. He's practicing in the States. And I follow him because he posted operative video on daily basis. And he posts this, but you can find the time, 5 p.m. also at the same time. And the title was Giant Partially Thrombosed MCA Bifurcation Aneurysm. And I say, wow, this is a coincidence. But after I go to the video, I impressed even more that I will mute the voice, sorry. I impressed more by it's the same aneurysm. It's the giant partially thrombosed. This is the aneurysm he's describing. And it's on the same side, left side. And let's show you some picture that I'm impressed with it. Yes, you can find, you can see it's can see he's describing even the same angle that we put the patties, and what an coincidence. You can notice this is the same aneurysm like us, like our aneurysm, and I don't think he operated at the same time, but he posted at the same time. That's the idea. And also he opened the aneurysm, and also by chance, it's the same location that we open our aneurysm. Maybe only the clot is different, or the thrombus part is different. He's evacuating it. Same steps. I will put the link for this video for Dr. Mustafa Biskaya in the video, in the first comment of the video after posting it, because he described it in very interesting way, and he used giant clips, also cutting the aneurysm, and at some point inside the surgery, he makes some sutures. He said that I make the resident do some suturing. It's an old one, not needed, but why not 5 minutes just to secure part of the aneurysm. And the final is this one. It's not a regular shape for clipping, as always with the MCA. So with many, many coincidences. That's what I want to say. And going back to the presentation, that's the idea for our presentation today. I will be open for a question after a few seconds. Our next presentation, I think, will be this week. I will arrange that with the I'll arrange that with John about our new book just published before maybe 2 weeks, the Neurosurgery Board Favorite Crossword Puzzles. It's an interesting, let's say, entertainment book, but actually there is a lot of efforts inside this book, neurosurgery-wise, and to make the study more fun. I think the presentation will be in a few days later, and I think next month will be the neurosurgical, or cracking the neurosurgical radiology. There will be an online course for 4 successive days. It was delayed for the next month. This will be our next lectures, and all the effort done by standing on the shoulder of giants, and all done through Teams. And thank you.
Okay, Samra, thank you very much. And we'll open the panel for discussion. I want Redab, I wonder if you might lead the discussion, since she is a neurosurgeon.
Can I speak?
Thank you.
Go ahead, Redab. Let Redab. Go ahead, Redab.
First, thank you, Dr. Samer, for this fantastic presentation and extraordinary work with this giant aneurysm. It's really a new technique, and it's not that common. And it's really a nice coincidence with Dr. Baskaya, just doing the same time, the same location, and the same technique almost. So congratulations for the great work, and always proud of you, Dr. Samer.
Thank you.
Dr. Omar, you want to say something?
Okay. I speak in Arabic and in English after that. Okay.
Okay.
I still one notice. At Arabic, at Quran Kareem, ولا يحيطون بشيء من علمه إلا بما شاء. هيدي رب العالمين حط التوقيت، سمح بهيك بعمليات بهاللحظة هاي. إذا بتذكر اللي اخترع التليفون، واحد بأمريكا وواحد بأوروبا، نفس التوقيت، فرق بالساعتين بين ذكرت اخترع التليفون أول مرة. I speak English now. Dr. Professor John, I speak in English. There's a Quran Kareem, any science not come only from Allah. At the same time, when our God or our Allah, He let us to know maybe a different area, same time. You know, before the 100 years about telephone at USA and American, two scientists for telephone recovery. You know, Bellingham, as I think Bellingham is. I forgot his name. 2 things, 2 hours between them. To them. I speak to Dr. Samuel Sanko, very interested lecture. I speak about I compare between you and Dr. Subeh. Dr. Subeh, like tumor, false tumor of GBM. You are also false tumor like aneurysm. Okay. Second things I tell you about this case, not tell us about what the symptoms about the patient and the signs you examine him. This is necessary to make surgery or not. What he has symptoms as a patient, how he come to you, where he come, the history of the patient, please. Thank you very much for you.
Okay. Thank you, Dr. Omar. Thank you for the comments and thank you for the question. Yes, I think I mentioned through the description of the video that the patient initially presented with the headache and recurrent seizure attack, but a few weeks, I think 2 weeks before the surgery, the patient has an attack of rupture with the sudden severe headache and nausea, vomiting, neck stiffness with the meninges mass. So it's a combination of mass effect, and I think it's a minor rupture. You know, there's sometimes a minor rupture, not major. Otherwise, the patient was healthy, no motor deficit, and the speech was intact. All the procedure done under intraoperative monitoring, MEP, and the free run EEG and somatosensory evoked potential. Especially at the time of temporal clipping, we depend on the neurophysiological monitoring that was of paramount importance during the surgery, because we don't have ICG at the current time. I think on the next weeks we will start using the ICG, but at the time being, we depend on the neurophysiological monitoring, and actually it's a fruitful tool to guide us through the
Doctor.
Okay, I think his internet connection was disconnected. He'll be back. Oh, there he is. Okay.
Okay.
Sorry.
Okay.
Yes. I think I finished the answering
No,
the question.
I continue. I one question, small question, please. For this patient,
yes, sir.
his Glasgow Coma scale is 14/15 yearly.
Preoperatively 15.
15. 15.
Preoperatively
Okay.
15.
Can we wait this emergency surgery or not?
No, it's on elective surgery. We prepare
elective. Can we? But I tell you, this surgery is very good for teaching. For teaching, very good. Okay, very good for teaching residents. I ask, can we wait? And this case is very good to compare for up many years for clipping, 13 clips on one case. What's the follow up after 4 years? This is clinic for bumping the brain. Is make any things we must to follow. This is our first thing. Second things, if we follow up without surgery, like disc, like disc, surgery or not surgery, to compare 2 cases. Okay, I think that we are not this case, not emergency. Can one case to follow without surgery, or another case to surgery? I think that okay. Thank you very much for you and to all.
Thank you. Actually, yes. If it's totally thrombosed or in such age with fixed size and there is no new symptoms, for sure you can observe this lesion. Not every aneurysm for surgery, but in this case we have an attack of bleeding, a documented attack of bleeding, and the patient presented with resistant seizure. She used 2 antiepileptic drugs and still have 3 seizures per week. So that's why we try. I would not like to operate such aneurysm with the 60 plus age, you know, sir. If it's a 20, yes, it's definitely indicated for surgery because it will grow with time. And 60, we can wait. Why to be in hurry? But the symptom of the patient give us the indication of surgery, and it's a combined decision between us and the surgery. And also at the same time, there is no endovascular option at this case. That's very important point. There is no endovascular option for this patient. If there is an endovascular option, yes, let's do endovascular first in this age.
Yeah, I think this is very good for teaching about for making surgery. Very good, very good. Work of many clips, you know.
Yeah.
And very tumor, forced tumor aneurysm. Aneurysm, I like forced tumor. This is atopic.
Yes.
Okay, very good. Thank you very much for you. Very good for all.
Thank you, Doctor.
Thank you,
Thank you, Dr. Omar.
Thank you very much for you.
Thank you. Yes, Dr. Radab, if anyone
Okay,
has any question, I'm ready.
okay, we'll just keep moving along. Does anybody else have a comment or question? The floor is open. It's your opportunity to talk to a real neurosurgeon.
Dr. Samar, I think we can describe it somehow similar to kind of AVM resection, where you do that circumduction, dissection of the thrombosed aneurysm from the surrounding tissues. So would it be somehow similar in technique-wise to the AVM dissection, or it's even more dangerous, or whatever you can describe it?
Yes, that's a brilliant question. I think I use the word in passage vessel, and that was exclusively for AVM, just based on the same idea that this aneurysm, part of it is aneurysm for sure. Part of it is AVM with the dissection around it and preserving the in-passage cortical normal vessel. And part of it is a tumor resection, as Dr. Omar said. It's while doing the internal debulking, it's a tumor resection. So it's a combo of many surgeries, but I think I found it interesting, more easy than maybe small aneurysm in difficult locations. Actually, we are happy with the result and with the patient. That's the most important. For sure, I will follow the patient for a long-term period. I will pray for the clips to stay in position. And we need to know what are the possible complications. And right now, I'm thinking about good coverage with antiepileptic, because I think this multiple clips may be irritant to the cortex. And yes, back to your question, part of it maybe looks like AVM.
Thank you, Dr. Samar.
Okay, thank you very much, Samar. You've already mentioned the next webcast. Will be when the next webcast?
It's up to John.
Yeah, it's up to me. When do you want to have the next webcast?
Because we are getting in quarantine now in Iraq, so every day at night it's okay for a presentation.
Okay, we'll be in contact by texting. Okay, and thank you everyone for coming. Thanks, Rejab, and thanks, Omar. And we'll see what the hang around. We're just going to end. We can
Dr.
network.
Ilyas, no speaking, Dr. Ilyas. Why?
I'm sorry.
Why, Dr. Ilyas?
Oh, I
Hello.
don't know.
Hello, everybody.
Hello. How are you?
Oh, I'm
voice.
sorry. I'm wrapping up too soon.
No voice. Why?
Okay, well, let me just end the webcast and then we'll just chat. Okay. Let's go.
Okay.
Thanks everybody for coming.